Good day, everyone. Good day. Good day. I trust it's been a very beautiful day. I want to thank everyone who's joined in already. We trust to have more persons joining, and we expect to have more persons joining as we have begun. Welcome to our special webinar session celebrating the World Pharmacy Day. It is such a special day for us over here, and we thought to celebrate it this way. So the World Pharmacy Day is usually celebrated on the 25th day of in the month of September every year, and it honors the pharmacists and have vital role in healthcare, emphasizing their contributions to patient care, safe medication use, and pharmaceutical advancements, promoting well-being globally. And today we're honored to have a very distinguished speaker who is going to be discussing with us healthcare delivery in the 21st century, pharmacy strengthening health systems. I'm quickly going to introduce him, and then we would begin the session right away. So very, very quickly, we have with us who is going to be engaging us on the subject, Professor Cyril Odianose Osifo. He's a highly accomplished pharmacist and an academic. He's obtained his B.Pharm, MSc, and PhD degrees before joining the University of Benin in the year 1993, where he later became a professor. Notably, he served as the head of the Department of Pharmaceutical Chemistry and the Dean of Faculty of Pharmacy. His contributions extend to supervising numerous successful MScs and PhD students, publishing over 100 scientific articles, and actively participating in committees within and outside the university. He has received prestigious international and national awards and is a member of several professional organizations. Currently, he holds the position of president of the Pharmaceutical Society of Nigeria and remains actively involved in community and church activities. He's married to Professor Mrs. Stella Osifo, also an accomplished academic. Please join me, everyone, as we have the honor to have him with us as we celebrate the World Pharmaceutical Day. Take us on this session. Thank you so much. Thank you. Please, and join the people around you to join. It's going to be very enlightening and engaging. So over to you, Prof. Thank you. Thank you so much. Thank you.
Thank you, thank you so much for having me. I appreciate the opportunity you're giving me to discuss an interesting topic on World Pharmacy Day. For us pharmacists, it's particularly interesting because we're all gathered here in Brisbane, Australia. We celebrated it about 8 or 9 hours ago, but at the same time, we have used the opportunity to engage colleagues and continue to do what is needful. The healthcare delivery in the 21st century will particularly focus on pharmacy strengthening health systems. For me, the approach to healthcare delivery in the 21st century and global health security requires a new definition, one that is multidisciplinary, holistic, and indeed centered on the safety and security of all people. Too often, we find out that governments have issues about national security when compared with health security. They tend to combine them together or interchange the usage of words. Because when you base this on global health funding, particularly on decisions on conditions have to be made that could threaten individual populations and economies. I national security must not be the primary justification for global health security decisions. And human rights, equity, dignity, and thriving development must also be central to this process as well. Having said that, I will quickly want to say that traditional approaches to health security result in unpredictable funding, which is unsustainable and works against the long-term solutions for healthcare challenges. Ensuring that healthcare delivery in the 21st century policies are to be viewed through a healthy, a health equity lens requires increased inclusion from low and middle income countries, more civil society voices, and an emphasis on human rights. This becomes very pertinent, knowing fully well that we live in a global village, and what happens to one particular part of the village affects the other area. The last pandemic did not exclude Africa, neither did it spare Europe or even the US. And therefore, a health system or healthcare system is an organization of people, institutions, resources that delivers quality healthcare service to meet the healthcare needs of target population. Going with this definition and looking inwardly in Nigeria, you begin to ask whether institutions are properly organized to deliver this. You might also begin to ask whether the resources are actually there. Because if you want to deliver quality healthcare, you need funding, proper funding. You and I know very well that most of the healthcare needs are paid out of pocket. There is a wide variety of health systems around the world, but the collaborative endeavor exists between governmental entities, labor unions, philanthropic organizations, even religious institutions, as well as other organized bodies. This is obviously aimed at the meticulous provision of healthcare services tailored to the specific needs of their respective population. We don't just import what we have outside the country and we want to domicile it here. We must also know what are our specific needs. The process of healthcare planning is frequently characterized by an evolutionary progression rather than a revolutionary transformation. I say that with all sense of modesty, that we need to develop our own healthcare system in a special way and let it progressively bring out what we want than just getting something that is outside there and we want to say that's how it must be down here. Health systems are likely to reflect the history, which is important, the culture, and the economics of the states in which they evolved. This peculiarity bedevil and complicate international comparison and preclude any universal standard for performance. Health systems should include not only the institutional or supply side of the health system, but also the population. A health system should not be expressed in terms of their components, but also their interrelationships. Health system must be seen in terms of their goals, which include not only health improvement, but also equity, responsiveness to legitimate expectation, respect of dignity, fair financing, among others. Health system must also include the direct provision of services, whether they are medical or public health service, but also other enabling functions such as stewardship, financing, funding, and resource generation. Here we talk about the health workforce. And I think we must begin to appreciate the fact that the health workforce is something that I've picked up with some of my colleagues down here. It looks like we are generating, we are producing the health workforce and exporting to other countries. Of course, we know the Japa syndrome, but we may not appreciate what is going on. Some countries are folding their hands and harvesting our health workforce for their own good. And we must begin to talk about the politics of good distribution of some of these facilities that we have, especially with the work health force. About Nigeria, it's peculiar. We must understand that it's the largest economy in Africa. And it's a lower middle income country with a real GDP size of about 432.3 billion by the end of 2020. It is a decline, 21% decline from 214 GDP figures of 546.7 billion, occasioned by 2 contractions and 2 recessions within the period. Per capita GDP reportedly dipped from 2,327 billion as the case would be. GDP from 2,327 in 2010 to 2,230 in 2019, representing a decline of 4%. But your guess is right as mine that this has further declined almost every week, if not every day. There is a further decline, of course, with the devaluation of the Naira. That means that to get a lot of things, even the institutions who provide these health services, if they need fine chemicals or they need a piece of equipment, it becomes more expensive. The Nigerian economy is largely dependent on crude oil, we know, and that's where we get our foreign exchange. The crude oil output had been put under 2 million barrels per day in 2018 to 2021, except in 2019. Declining oil prices in international market have had negative impact on our country's earnings. Then COVID-19 had the greatest impact, with prices dropping to as low as $42 per barrel at the end of 2020. The consumer price index, that is inflation rate, averaged about 15.9% in 2021 and stood over 21% in October 2022. But as of today, it may have almost skyrocketed to over 30%. The inflation presently now is higher than 23%. I presume it may even have gone to almost 30%. We need the statistical data from appropriate institution so as not to guess. The private sector, which includes the Lilly Hospital, is a major pillar driving economic performance in Nigeria. A review of the IMF data shows that the private sector component of gross national savings averaged about 25% of GDP from 2018 to 2021, while the government savings averaged about 1.65% of GDP, with no net saving recorded. In terms of investment, the private sector accounted for 89% gross national investment compared to the government's 11%. What that means is that the private sector is doing quite a lot. Well, our president is a private person, a private sector person. Let's see what it will bring to the table with the weeks and months that come by. An important parameter for economic growth and by extension, attraction of investment is the allocation of credit to private sector. That is my own take in this matter. If you want the country, if you want the economy to improve greatly, then you need to get enough credit to the private sector, including the hospitals. Gone are those days when public activities becomes free, but we must be able to pay for our services. And if you invest in private sector, they will do more, especially if they have credit. For Nigeria, the growth in credit extension to the private sector averaged about 12.25% from 2018 to 2021. It's ever projected to decline, not increase, to 8.6 in 2022, and might even be worse than predicted. Another factor hindering private investment is the uncertainty around a devaluation of the Naira, which is fueled by continued foreign exchange shortages, rising inflation, among other contributing factors. The recent election in 2023 added to the uncertainty in an unprecedented way, but the good news is that we are getting out of the woods. That's my own take on the matter, and I believe that we should do that with all forms of honesty. Now, what about the ease of doing business? You might say, where's pharmacy coming in? We're talking about economy, but it's important. If you want to strengthen the health system, then of course the economy has to be on the right footing. Doing business was an initiative of the World Bank designed to provide objective measures of the various dimensions of the regulatory environment as it applies to local firms. Nigerian healthcare sector is grossly underdeveloped and does not meet local needs. Much of the country's healthcare infrastructure is confined to major cities, where people live in urban areas, getting 4 times as much access to healthcare as those living in rural areas. The private health sector is dominant or highly fragmented, consisting of many small medical facilities or health facilities that are privately owned by medical professionals. And most of these hospitals, have less than 10 beds and minimal facilities. The Health Facility Registry, HFR, or the Federal Ministry of Health, estimated that about 39,000 plus, almost 40,000 hospitals and clinics exist in Nigeria in 2019. Over 70% of these facilities are government-owned, for our information. Demand for healthcare service in Nigeria is projected to increase over a 5-year period from about $15 billion in 2018 to over $18 billion in 2023. The health sector contribution to the aggregate real GDP stands at an average of just 4%, with out-of-pocket expenses accounting for 74% of the total money spent in the sector. The growth in the health sector is largely attributed to the increased investment committed by both public and private sector players as part of measures to contain the pandemic as well as address other growing needs in the market. And I believe Lily Hospital is doing very well in that. We even look back and say we see that the primary healthcare centers account for about 85% of this number, while secondary tertiary health facilities account for about 14.4% and 0.4% respectively. It might, for the record, Nigerian population is estimated at 200 million. I guess it's more than that by the end of 2018, growing at an estimated rate of 3.2% per annum and up to 2.5% in the year 2000. The population is young, with 63% of the total population under 25. Children under 15 account for about 44%. That is huge. And youth aged between 15 to 24 account for about 19%. Of the remainder, 34% are adults aged between 25 and 64, while we have just 2.8 elderly over 65 and above. These demographic figures show that Nigeria population is still very young and in the short to medium term. The healthcare value chain, including pharmaceutical value chain, is a system of interactive components working together towards delivery of improved quality outcomes for key stakeholders. Such stakeholders spread across the demand side, largely patients and other consumers of health services. Supply side, like health providers, care providers, investors, regulators, researchers, drug manufacturers, among others. Providing adequate healthcare to these populations remain a major challenge to government in Africa, Nigeria in particular. Pharmacists can and should strengthen the health systems to provide the needed robust positive health indices. Unsatisfactory and inadequate access to essential drugs and other healthcare commodities is a key limitation that impacts on people's health in most developing and least developed countries. I want to quickly say that we have the capacity, we have the workforce that can do that if properly encouraged to do so. The Dangote refinery is a petrochemical industry, and I want to believe that with time we should be able to provide the active pharmaceutical ingredients, API, that will engage more pharmacists, and pharmacists can provide the needed medicines that we need in this country. Nigeria has identified the local production of essential drugs as an important component of a long-term solution to the provision of adequate healthcare in developing countries. Pharmacies have participated actively in this, substituting generic products for branded ones that are less expensive or meet the necessary bioequivalent and bioavailability data to enable patients procure this medicine for their use. Adequate access to drug is dependent on both affordability and quality of the product. When it comes to quality, NAFDAC is there, but we must also realize that it's becomes like all commerce trade. Everybody goes to, they see medicines are commodities they can trade in, even when they don't have the proper training. But in as much as quality shouldn't be compromised, we also believe that it should be affordable. We realize that the average Nigerian who goes on with 30,000 can probably afford a good medical care, maybe in your facility, if he has a particular illness. So we want government to provide the necessary infrastructure so that we'll be able to work together in the healthcare system. Unaffordable drugs are clearly not the solution, to my mind, but equally affordable, low-quality products are not the answer either. So these are problems. If you you say the drugs are not affordable, they are expensive. But again, if you have affordable, low-quality drug, they probably will not give you good outcome, therapeutic outcomes. Therefore, an industry that produces high-quality drugs at competitive prices must be the target when developing local manufacture of drugs, of pharmaceuticals in Africa or in Nigeria. And this is where pharmacists come in. This is where we strengthen the system. This is where we bring in our know-how. This is where we are able to also make sure that alternatives are provided to help the masses. The pharmaceutical sector is a complex one, involving many stakeholders such as manufacturers, national regulators, government ministries, wholesalers, and others. Developing the industry requires a concerted action across these stakeholders to create the environment in which the industry can flourish and realize its full potential as an asset to economic and social development. And I dare make bold to say that if we get this right, we'll become a foreign exchange earner for the country because we can supply the West African sub-region. An example of the role of different stakeholders can be seen regarding the scourge of counterfeit drugs, which cause huge health problems and represent a threat to legitimate manufacturers who effectively must compete with these substandard products. And this is where pharmacists have come out robustly to help strengthen the health system, to make sure that only quality drugs, reputable manufacturers who will not fake products are admitted or allowed to supply drugs and are allowed to get their products in the market or in the hospital facilities where they are. Regulators must also act to reduce the penetration of counterfeit drugs. This would as well as been important from a health perspective, also from a local pharmaceutical industry. Furthermore, quality requires upgraded skills and equipment. And I believe Lily is doing that, making sure that the pharmacists get some of these upgraded skills attended to. Pharmacists can also produce high quality products at affordable prices. This challenge requires various government ministries to work together to establish the support to the industry that will enable efficient local companies to invest in high quality production of medicines. Well, at a time when health systems around the world were recovering from COVID-19 crisis, and consensus is that urgent action is needed for health services to meet future needs. This year World Pharmacists Day campaign presents opportunity to increase the awareness of pharmacies as an intelligent solution. COVID-19 has presented undeniable evidence of capacities and capabilities of pharmacy profession to support health system. According to the International Federation of Pharmacists member organization, the American Pharmacists Association, for example, during the pandemic, pharmacy teams in the US provided over 350 million clinical interventions in form of COVID testing, vaccination, treatment, and inpatient care. There are things that we can do so as to be able to mitigate some of the incidences we have and give us room to not only work in the team so that the patients become the ultimate beneficiary of the services that are provided. Pharmacists also check for drug interaction, also check for overdose, and a couple of other things. Give pharmaceutical care and advice to the patients appropriately. Pharmacy is essential to access to health, a safe supply chain, and responsible use of drugs. Community pharmacists, for example, strengthen the healthcare system through providing advice, information, education, treating and then screening and testing and referrals, administering vaccinations, prescribing and reducing poorly medications and follow-up. Pharmacists have also have the skills to take on the management of patients with long-term conditions such as diabetics. Advances and progress in all countries and territories are needed if we are to achieve universal health coverage. As we strengthen the system, we work as a team with every other health professional. Therefore, many international agencies and think tanks define a well-functioning health system as having 1, accessible and reliable supply of medicines and technologies. 2, trained and motivated healthcare workers. 3, good infrastructure. including improved governance of a particular system. 4, evidence-based policies. 5, strong planning. And finally, adequate funding. I want to thank you for listening.
Thank you so much, Prof. Quite concise, but very enlightening and educating. You know, just listening to you speak just brought some form of hope. Yeah, that there's indeed hope for our nation, Nigeria. And that there's hope for our health sector as well in Nigeria. Thank you for that amazing presentation. I did forget to note whilst I was trying to introduce you that, yes, that Professor Cyril is the president, is the PSN president, Pharmacy Nigeria. He's not a small man at all. And we're once again honored, Prof, for the time you're spending here with us today. Thank you so much. Thank you. Very quickly, so we're going to be entertaining. Yeah, thank you. On behalf of Lilly Hospitals, we're saying thank you. So very quickly, we're going to be entertaining questions around the subject that has been discussed, already. And we got questions sent in from the public. People are asking to know, to have some concerns addressed in this regard. And I'm going to begin the question time from those questions. So, Prof, we have a question directed here to you. Okay, it's saying, how can academic pharmacists partner with hospital pharmacists and hospital pharmacists in the areas of research and implementation science to strengthen our healthcare system? Do I have to take it again, Prof?
Okay. You want me to take that on now?
Yeah, someone is asking. It says, once again, may I just take the question?
I can go ahead and...
Okay, great.
Okay.
Please go on, sir.
Yeah. No, I got the question. Okay. Can I go ahead?
You can, Prof. You can, sir. Okay. Thank you.
Okay. Academic pharmacists are from all ramifications trained pharmacists that practice in various aspects, whether in the industry, hospital, or community pharmacies. And I think one of the things we can do a little bit more specifically, we can strengthen the health system in the hospital. If I hope I have the explicit permission of my wife, I think so. We can discuss that. We can afford to have what you might call clinical rotations of pharmacy students. For example, in Lilly Hospital, then the academic pharmacists and the pharmacists and even the healthcare personnel can interact, and then the students can be trained, and then we can also make contribution as to what we are seeing and what we should see. And it becomes like a cross-fertilization of ideas that goes on day in, day out. In that way, we can make very constructive criticism that will help. And you can also criticize where necessary, and it becomes a symbiotic relationship. In addition, academic pharmacists can be involved in research, which we would do, to enable you benefit. For example, you get drugs and you are not too sure of the quality of that drug, or before the drug is taken in, we can help with the analysis and give you unbiased results of what we've seen. I remember very well something happened in UBTH, and the drug that was administered didn't have the required outcome. I never knew that there was a problem, and it was brought to my lab. We carried out the analysis, and we didn't even get up to 40% of the active ingredient. I wrote my report, and I stood by it. And when the clinical presentation came, we found that it was substandard drug that was supplied. I mean, if you know somebody who supplies such type of medicine, that person should be outrightly banned or probably sanctioned, as the case would be. So these are some ways we can collaborate, and research particularly. If we can do what I call therapeutic drug monitoring. The drug you might give for patient A, patient B comes with the same ailment, and one reason or the other, you're not getting good outcomes. We might check whether there are other comorbidities. If you might also, we might also check if there's drug-drug interaction, or even the food the patient is eating. You might probably say, patients stick to the food that Lilly Hospital is supplying, but behind you, the patient gets some other type of food from home that might probably interact with the drug, and probably there you won't get good outcomes. So there are many ways things can be done if given the opportunity.
Prof, thank you for preferring that. Thank you. I hope that everyone who's connected, we are beginning to find strength and courage and hope again in our nation, Nigeria. So, Prof, this sort of is like a follow-up or a follow-on of the question you just attended to now. So this person is asking, how can we encourage capacity building and collaborative efforts with diaspora to address healthcare issues in Nigeria?
That's a that would help with technology transfer. That would help to make sure that people learn at short notices. Let me tell you one thing I did when I was dean. We have right now. We've had her for almost 10 years. She is a visiting professor from the United States. She's in the diaspora. She's a Nigerian, and she loves contributing, paying back. That's what she calls it. And so we have her every year come down. The university is gracious enough to pay her ticket and accommodate her, where she does not only teach and grade scripts, but she also participates in World Run and give lectures generally to other people. That is one way. I can assure you that there are a lot of, we have this diaspora connection for pharmacy, Nigerian Association of Pharmaceutical Scientists, or pharmacists and pharmaceutical scientists in the Americas. Many are willing, very, very willing, to assist in capacity building. Now, thank God for COVID. One positive thing that came out from COVID is that we don't necessarily have to be physically there. So we can look at topics that are very interesting and maybe suggest webinar to build capacity for staff in Lilly Hospital, not just only pharmacists. And we'll get the appropriate person who would deliver a series of lectures. And I think that could be pro bono, and things will work out well. So we can do that. And in addition, we can also, once this collaborative program is built, it helps us to fortify our relationship. I remember I traveled down to the US with Professor Nato, and we went and we discussed to the point of signing an MOU with my university. I remember later Professor Oshodin, our VC, was the vice chancellor then. And when we came back, we gave our report. And I now remember asking the vice chancellor, you may, that's the language, you may, if you choose to, decide to bankroll our expenses, which we have included. We didn't ask the university for funds, but we decided to help the university look for collaborators, people who could build capacity. And he was quite pleased with that. And indeed, he paid us the expenses and even took the paper to send it to tell people this is what people should be doing. So those opportunities, there are persons in the UK, there are others even in Australia here, as we found. So I think it's a good opportunity, and we can work closely with Lilly Hospital and see how we can do that, or any other organization, as the case would be, not necessarily Lilly Hospital alone. We are quite open and we are willing to collaborate with our colleagues.
Prof, we're open to such opportunity, really, and we look forward to it. Maybe after this time, we would engage in that regards much more. Thank you so much, sir. So, sir, here's another question coming in. It's saying, in the clinical healthcare setting, aside the pharmaceutical care delivery, how else can pharmacists strengthen the health system?
one way which is not normally discussed in the classroom is to be part of a think tank where policies are made. It may sound a little bit strange, but I would posit that if you are not where decisions are made, you may not be able to tell people what you want to do. Rather, decisions will be made and passed down to you that could affect your business, affect you as a person. What am I trying to say? We should be willing to discuss what we have with the necessary persons who are in government, or put it there, become influencers. If you know a governor or you know a minister or even the president, you can take your fight there and say, this is what we want. The reason why I said so is that we must begin to intentionally take the healthcare system, we must take it to a higher level. And when pharmacists are involved in policy making or can influence policies, that would be to a greater extent one way of strengthening this health system. Two, we must begin to educate people, especially at the rural level. We know how our late Professor Ransome Kuti came with the primary healthcare delivery system, sorry, healthcare, centers over. It was like, let people not come down to the city, or let people not come down to the tertiary institutions when they can do certain things that will avoid them coming to the hospital, because by the time you come to the hospital, at times it becomes too late. So we must be involved in primary healthcare activities, begin to educate people on what they should do and what they shouldn't do, so as to improve their health, their health in general. Number three, we must also allow people who are involved in pharmacy practice by making sure they are properly, that's part of capacity building, which you talked about, to build them up, to learn a lot of things. We shouldn't be satisfied with what we have learned. We must be willing to learn more. And I think finally is in terms of technology. Technology has improved quite a lot, and they must be involved in technology to able to strengthen the health system that we have of the day. I'm sure if these things are put together, the pharmacists will be able to make meaningful contribution to strengthening health systems in the country.
Thank you so much, Prof, for that contribution. Thank you. Very quickly, I have a very interesting question here for you, Prof. It's saying, why has drugs lose its value in the 21st century? I have so many complain of drugs not working, and why? Also, when will prescription medicines be regulated in Nigeria? Thank you.
Prescription medicines be regulated. Well, let me start from the back. They are indeed officially regulated. That's the truth. But the question I ask is, if you get a prescription, how many of those prescriptions will a community pharmacist see in a year? If he's lucky, they get about 20. That means the prescription doesn't get to where it's supposed to get to. What that means is that even if the physician says, go get your drugs or your medicine from that pharmacy, the patient may decide to go elsewhere, go to a patent medicine store or go to places that are not registered. If that continues, then there are issues. Two, there are also issues of people who probably prescribe these medicines, they stock, and then give the medicines to their patients as well. And then you now also have the issue of people who probably had come maybe to Lilly Hospital and was treated for a particular ailment. He goes back and now finds out that he has something a little bit similar to what he was treated. The next thing, he becomes his own physician and pharmacist and prescribes for himself. We know that we always say, please don't don't do self medication. Go to the hospital. But how many hear that? So these are some of the issues that we have at stake. But in as much as you have drugs in the open market, which we are tackling very seriously, we continue to have issues about regulated, this prescription regulating properly. I think because if drugs or medicines are the reach of any person, then you will have issues at our hand. I know in a society where people, I tell people that when a wrong drug enters the wrong hand, and people are maimed or die, such persons who are involved should be properly dealt with. But people don't realize such a thing. I don't want to digress so much. There's something I could have easily said that has caused a lot of problems in our society. Maybe towards the end, if I have time, I would discuss that. The other question the first question you asked was, I've forgotten that now.
Once again, is that why has drugs lose its value in the 21st century?
Yeah, I got the point.
We've
okay,
got so many complaints of drugs not working.
Yeah.
Why?
Number one reason is poverty. People want to get rich, and so you pick up a medicine. You have counterfeited medicines, substandard drugs. Now, if somebody, you may be surprised that somebody legitimately will buy a particular brand from the pharmaceutical company. Let's say what about, say, 1 million units, paid with his money. It gets to his own backyard and has all the facilities, and then fakes those drugs and make sure they don't contain anything. And he now puts into the market, together with what he bought genuinely, another 5 million units. I'm just giving an example. So you have 6 million in circulation. It makes so much money, and even churches will call him and mosques to come and donate. He donates and they pray for him. But meanwhile, he has about 5 million units in circulation and only 1 million that are genuine. If somebody gets the 1 million out of the 1 million, the person is cured. But if the person does not get that or gets a mixture, you have therapeutic failure. That is one basic thing, counterfeit drug, which there's no country, even the US, even US and Euro, you have counterfeit of drug, but the percentage is lower than what we have here. And that's why I always try to say we should draw more support for NAFDAC. And NAFDAC should be well positioned to be able to enforce certain things. Two, counterfeiting, poverty, one, counterfeiting, which is linked to that. Another point why we don't have these things is that storage facilities. Now, if you take a vaccine, I've seen somebody who would buy some medication, some medicine from Onitsha or whatever, transported in the vehicle, gets into the shop and puts them in the refrigerator. Who is the saving rule? The potency would have been affected. And so the unsuspecting patient comes to buy this particular medicine that's supposed to be in the refrigerator, and it says in the refrigerator, but doesn't know that during the transit, during the supply chain, the cold chain have been broken, and this happens often in the country. And so some hospitals are beginning to say, look, the company should supply some drug to us directly and not buy from a distributor. But if you buy from whoever you want to buy from, the person has to be a reputable person who will not undermine quality. So the story, like I mentioned, is one of the problems. Then we also have situation of, wrong prescription. What do I mean by wrong prescription? If you prescribe a particular ailment, particular drug for a particular ailment that's not the right one, you won't get any outcome. Or in some cases, like I remember during the Abacha time when you had people who were not pharmacists procuring drugs, going to India and procuring what you have. PTF. I remember very, very well that the chloroquine sulfate that was produced were substandard. They were made for children or they were dispensed for adults. So you could also have some amount of deliberate way of doing something. People deliberately telling people, please, instead of 10 milligrams, let's have 5 milligrams. It's my country, we know what to do. Finally, I will also say that we need concerted efforts from everybody. If you see something, say something. If you hear something, tell the necessary agency. That's exactly what NAFDAC is saying. They cannot police everywhere. But if you know somebody doing something that's unscrupulous, please let us know. Let PSN know. We'll be able to escalate this thing at the appropriate quarters. I think with that in mind, if put them together, there's definitely going to be something that will be used. But I hope and I believe that colleagues or rather friends who want to procure their drug should procure their drug from a reputable pharmacy. If somebody tell you drug A is 20 naira in this place, and you go to another place, they tell you it is 5 naira, you should begin to ask yourself what is going on. I don't want to talk much on the drug market, because these are avenues for faking drugs. But I think the necessary authorities, we are working closely with them to see how we can put an end to this. I'm sure you people must have seen what happened in Kano. The then governor, I was there with the then governor, the registrar, Minister of Health was even there, Dr. Hanere, and even a few other persons, where we made sure that you have a coordinator wholesale outlet where everybody should come on, it should come into. NAFDAC will be there, PCN will be there. But some individuals don't want to go into that place. They went to court, but court has ruled that they should go in there. Because when everybody, if you now procure your medicine from elsewhere, it becomes illegal, you can be arrested. So if Kano is able to get that done, maybe next we'll move to Lagos and eventually nature. But we need to be a little bit patient. God helping us as we work with the new minister to make sure we achieve some of these goals. Thank you.
So much. So just before we would bring it to a wrap, just before we would have Dr. Kimoni Ikutegbe, one of our EDs here at Lilly Hospitals, bring the closing remarks. Please permit me to just take last but not the least question I have here. So someone is asking, who really is a pharmacist, and why is there the synergy between, why is there no synergy between the pharmacist and then the pharmacy technician?
Okay, thanks. Well, the pharmacist, we don't need to dwell much. We say is the custodian of drug, is the expert in medicine. A pharmacist is somebody who has undergone proper training in an institution about pharmacy and all its ramifications. And most have also undergone tutelage, which we call internship for 1 year under a registered pharmacist. And in Nigeria, you would have also done your NYSC. But after the internship, you are a pharmacist. But like our license will say, somebody who can dispense compound and also procure drugs and work in various systems. And even right now, pharmacists are involved in many other things. But by and large, when it comes to medicine, the pharmacist take the front row, and it's actually the first point of call most of the time. First respondent when people are having some ailment. And like I mentioned, one of the things the pharmacist does is to make referrals to the appropriate hospitals or clinics where further actions can be taken. The pharmacist also works with community and to make sure that proper advice is given to them concerning what they need. There are times they would advise patients properly why they need to use medicines, or at times why they don't even need to use medicines, so that they'll be able to get the best. The other question, I don't think there is, the pharmacist technicians, they are a support base for making sure that drugs or medicines are well dispensed and that the patient gets the right drug at the right time, in the right place, in the right dose. Incidentally, the Pharmacy Council Act, which was signed into law by former President Buhari, they help properly. They are part of our council, and basically their function is to assist pharmacists and to be able to make sure that the patient gets the necessary pharmaceutical care. And then we also realize that pharmacists work closely with them. The pharmacy technician work under close supervision, and then we are able to work. Right now, they are even, I think they have a conference in October, and I have given them, they visited me, and I'm sure I will be at their conference, or at least my deputy president will be there. But I would say in our council right now, they are part of our council. So they discuss, the council is the highest legislative body, so to say, in pharmacy council. So they're in our council, they hear everything that we discuss, they participate, and also help in policy formulation. If we were not interested in them, there's no way we would have written in the new bill, we would have included them to be part of the council. They are part of the council. And we have also encouraged a couple of them, and it has happened. Some have already graduated, and I'll take the fight to many universities. Those who are willing and have the requisite qualification, we encourage them to become full-fledged pharmacists. So I think maybe it's a wrong impression, or probably some may have some difficulty, but if where they have issues, I'm there, they can easily reach me, and I will be able to step in appropriately.
Thank you so much, Prof. Thank you so much. We wish to have our participants here. If you have need to clarify or ask a question, please, we can quickly take that before we have the closing remarks from Dr. Kimoni. But before we do, I can see that we have Dr. Austin here, our CEO. Dr. Sir, good day to you. Can we have you please just bring in a word and comment on the subjects that we're looking at today? Okay. Yeah, yes, Doctor. Good day to you, sir. Good day.
Yeah, good afternoon, and good afternoon to our keynote speaker, Professor Sifo. We quite appreciate the insights you have shared during this meeting. I'd ask a question. I thought maybe I have the opportunity of you attending to my questions, but it's fine. I know that it's a busy day for everybody. We'll try to wrap up. It's very important that we're able to get such an important person like you to come and address us on this special day of pharmacy. And we're hoping that beyond this session that we can connect with you even after now to see how we can do more, within the pharmacy space. Because in the healthcare community, there is need for more internal interactions among professional groups to see how we can improve our collective service offering to the people that we serve. I had asked a question regarding what your thoughts are about the role of pharmacists and the PPMV vendors in primary care, and what you think we could do, looking at the special circumstances where we have social welfare personnel and the risk that we may even have, further worse situation with the ratio between either the pharmacy or the average healthcare worker with the population. What shall we do, to address, the needs of our people, particularly at the primary care level, where the regulation and the practices have been quite, not the best that we would expect. So I was wondering what you think, being the president of the PSN, and looking at how the entire industry is shifting away from what should be expected. What do we do with available resources, to improve primary care access, to our population?
Yeah, thank you, Dr. Austin. When I was delivering the lecture, I mentioned the issue of primary health care, which I think is crucial. If we're able to tackle certain things at the primary health care level, we might have less referrals, and will be able to nip whatever issue it is at the board. Most of the time, issues come down that are probably not tackled because there is no healthcare facilities at the rural level. Of course, you and I are fully aware that the young man who lives in university today would definitely want to be in the city center, not necessarily in the rural area. So there must be deliberate policy by government to make sure that the basic facilities in the urban area are probably also accessible in the rural area. That would probably enable people to be domiciled more in the rural area. If you take, for example, if there were rail facilities from, let's say, Auchi to Benin, I'm confident that many people probably would have lived in their father's home or live in the rural area where rents and other things are cheaper, where you can get food easily, and then people will get some benefits. Imagine if you have about maybe 10 physicians and 5 or 6 pharmacists in a particular primary healthcare center, or even if you have to work in UBTH or work in Lily Hospital, but you come back home, you can also attend to the needs of people who are around you, especially in the rural community. That could be one deliberate way. In a place where I trained, we realized that when people are in the rural area outside the country, they get some allowances which is higher. Yeah, their pay is higher than people who live in the urban city because of their willingness to be in the rural area. Additionally, I think there need to be more interaction, because when you have more interaction and cross-fertilization ideas, we begin to see that we're all working towards the same goal and not necessarily stepping on each other's toes. When I mentioned the issue of about in the US, where it's happening in Nigeria, where the issue of counseling and working with patients with diabetes being undertaken by some pharmacists, it also helps to reduce the number of patients and people that the physician may have to see. For example, if you go to a rural setting, you may see a physician seeing patients from 7:30 to almost 3 p.m. And that affects even his own mental health. If we can cooperate, we can actually make sure that this disease burden are reduced, because if there are people who need not see the physician because their medication have been properly trashed and need refilling and counseling, these things can be taken care of. And even ensure issues of chronic disease management, pharmacists can also assist to make sure that the best is come to the patient. If we come to the rural area, we can, as a matter of fact, classify the sort of people we have there, whether they are, very elderly, the percentage is small, or whether we have very young patients, whether there's a need to see a pediatrician or need to see an oppressive gynecologist, or just surgeon, as the case would be, or whether you have issues about people with bikes moving up and down, and when they move up and down with Okada, you may have more problem with people breaking their legs, so you might need an orthopedic surgeon. But by and large, we also need to look at issues of antimicrobial resistance and stewardship. We found out that this is one of the problems we have, that drugs are prescribed, but at the end of the day, we don't have any effect because of antimicrobial resistance. Some persons you prescribe drugs to, they just stop halfway when they think they are better and don't complete it. And tomorrow, if they have the same ailment or something similar, you give them the same drug, it will be no effect because of resistance. So a lot of education needs to go on, rural education of how people treat medicines and what they should do. I think finally, I also want to talk about people combining herbal drugs with orthodox medicine. That's a big problem because it has led to death of some people. And even some of the traditional practitioners at home, when they take their herb, they add some orthodox medicine, and just to win a lot of persons to their side concerning what they need to do. So I think if we put all these things together and work closely as a team, as a body, we'll get more better outcomes.
Thank you very much, Prof. Appreciate it. Thank you.
Okay, thank you so much, sir. Thank you, Dr. Austin. Can we please just quickly take Timi Tokwe's question? I can see that our hands are raised up. Timi Tokwe, can we have you quickly just ask your question? Tokwe? Oh, we can't seem to have her yet. But may I just bring in this question asked here? Prof, this person is saying, can academic pharmacists be given the privilege to work in hospital like their medical counterparts to expand their knowledge and to provide up-to-date information to their students?
The answer is yes. Depending from where the person is asking that question, the angle. Now, I know with our medical counterparts, they can work and get money and get paid, so to say. But we are working in that direction. But for now, there's nothing preventing you from giving whatever assistance you want to give. If you can do it pro bono, you understand what I'm saying? Now, if you come in to help, why not? It will be appreciated. I know a colleague in Germany who finished her PhD, and after her PhD, she went to the hospital. I met a young man in Niger who has a PhD, but working fully in the hospital. However, we can begin to look at, because I believe the angle the guy is asking that question from may be that if we work, we should get properly remunerated. One, the laws for now don't permit such things. I think that is so we need to go to the House of Assembly to be able to get some of those things. I've discussed with our senator properly, but I think that consultantship, which have just been approved by the federal government, could be a way of working that out. So we may be discussing with various hospitals and even and also the teaching hospitals around us on that. But I remember very well a classmate of mine who's a vice chancellor now. She was appointed in UI. She's a pharmacist, was appointed by UCH as a consultant, and she did the work effectively well, because we need all these opportunities that we have, not just for seeing patients, but also for research and therapeutic drug monitoring. So the opportunities are there, and I think clerkship will afford us an opportunity, and also we can also even admit them on, take them as locum, if not on full time, because they already have a job in the university. I know those in the teaching hospital, the medical counterparts, they are actually given an allowance because they are not in the employment of the University of Benin Teaching Hospital, for example. They are in the employment of University of Benin, and when they go to use UBTH, they are given some allowance. And so some of those things can be replicated as well.
Hello, sir.
Hello.
Yeah, good afternoon.
Very good afternoon.
This is Temi Tokwe calling from Lagos, Pharma News online editor. Yeah, I sent a question earlier.
Okay.
I sent a question earlier on, concerning how pharmacists can bridge healthcare gap in with negligence that we are seeing these days. A lot of things are happening in the healthcare sector. If we've been following up, we've been having cases of patients having issues here and there, though the case of drug abuse, substance abuse are there. Then the cases of mismanagement of patients not giving adequate attention and all that. I had one, aside the ones, trending in the media, I had a close colleague that had another incident at last Friday, and was telling me all that what have transpired. So I don't know, in what way do pharmacists come in here to bridge gap in healthcare delivery? Thank you, sir.
Okay, I think I mentioned a few things about that, but I think pharmacists must actively participate in health system, particularly the healthcare delivery, and also what goes on in whatever institution they find themselves. If I have been opportune to sit at UBTH board, and we've had some very robust discussions on what should be done. I was representing the University of Benin Senate in the board, and one of the issues I raised then, the CMD was my classmate, late Professor Badin. I asked a very genuine question. When we come for board meeting, we see the number of patients that have died in a month or 2 months or the quarter, as the case would be. But I asked one question that the next quarter, I will want to know the cause of death of these patients. I want to know what happened when they were brought to the hospital. You need some documentation. And by the time they started documenting, we now found one. Is it due to infant mortality, maternal mortality, or we now found out that about 50% of the patients were brought in almost dead on arrival. They came from some private facilities, and when they couldn't manage them further, they transferred them to a teaching hospital. And what that meant is that the University of Benin Teaching Hospital started kind of re-examining themselves. That is one way. Then there are also gaps about medication error. I mentioned that the pharmacist must make sure that whatever drug is given, handed over to the patient, is the right drug at the right dose to the right patient, and not possible to the right time. If you take a very quasi type of example, you take in those days have fun, and you take them with food, oily food particularly, you may have erratic bowel availability such that more will be absorbed than required. And what will happen is that the system could go into cardiac arrest and even death could result. So at times you need to advise that patient, when you take this drug, take it on an empty stomach. And these are things that you may not easily find, but that will help the patient so that you can participate and you become a team so that the patient benefits from all that should take place in the health system. I believe strongly that pharmacists are in a very robust position. They should also not be boxed to a corner or quiet. They should speak out their mind and advise the head team. Most importantly, that brings to mind the issue of rotations, and when you talk about rotations in the hospital, or you might call ward rounds. The ward round is not to show superiority per se. Ward round is to help build a team. I remember visiting an intensive care unit of a hospital in the US, and the consultant there told me, please help me thank the pharmacist. And I said, for what? So they help us, otherwise we probably check medication error for us. We work as a team. And I just said, this is beautiful because it helps to strengthen what we get. No man is a reservoir of all knowledge. We share knowledge. You bring in what you have, the other guy brings what you have. At the end of the day, the patient benefits overall from all the input from various people. I believe if we start practicing this together, then I'm sure we will always have good outcomes for us. Where you have some issues that are trending in the media, they couldn't have resulted if persons will not speak out. They would have spoken out to know the best thing to do. And I'm sure patients are beginning now to know their rights. And we must be careful how we handle patients. Otherwise, they could take us to court.
Thank you so much, Prof. Thank you so much for your time. Thank you once again for the valuable contribution you have brought in this webinar session in honor of the World Pharmaceutical Day. Your insights and expertise are greatly appreciated. Thank you also for sharing from your wealth of knowledge with us. We greatly appreciate this. Thank you. Very quickly, would have Dr. Kimuni Utegbe, one of our executive directors, just bring in the closing remarks before we would call it a wrap. Thank you. Dr. Kimoni.
Professor Cyril Odiano said SIFO. Trying to do a quick summary of such a extensive discussion would do it no favors. But to highlight on some things, your topic, the topic, strengthening health systems, is where my emphasis will go to, which is we who work in the health industry see the gaps and the potential that exists in collaborations, but mostly in making sure that our systems work. Too often, many parts of our systems do not exist, particularly in the rural or less resourced areas. And as we have had mentioned, the failures that happen when systems fail and patients or receivers of care then receive what might be substandard service. Particularly when you mention the fact that on the board in UBTH, in reviewing mortalities, you see quite a number of them are paying late. That also emphasizes the lack of systems where referrals and communication might not be open and multilateral. And we need to therefore improve and strengthen our health systems. I thank you very much for your presentation and obvious experience and expertise of in the pharmacy space and your efforts so far. There's a lot we need to do for our people to take benefit of whatever health systems we have, as well as to strengthen whatever is on ground. I thank you all for joining us on this talk, and I hope that we will continue to have more of this in the future. Thank you and good afternoon.
Thank you, Dr. Kimoli. Thank you so much. Thank you, Dr. Austin. Thank you for joining us here. Thank you once again, Dr. Prof. Cyril Sifo. Thank you for your time.
Very much.
We are grateful.
Thank you very much.
We look forward to more opportunities of this kind. Yes, where we'll have the opportunity to hear you speak again. Thank you once again. Thank you everyone who's joining for this webinar session. Thank you, and then to the pharmacy, to all pharmacists out there, I'm wishing you a very beautiful celebration as you mark your day. A very great day still. Bye for now. Thank you.
Thank you very much.